Hello, and today's lecture is going to be about kidney and the surgical anatomy. I mean, we won't get into the anatomy, but just the surgical pathology related to the kidneys. So, the first that we have to talk about is the nutcracker. Nutcracker is the nutcracker syndrome, and it is commonly associated with varicocele as well. Okay, so what actually is going to occur out here is that there's going to be the left renal vein is going to be compressed between the superior mesenteric artery and the aorta, which is the nutcracker syndrome, and this can sometimes result in a varicocele. So that's quite important when we talk about. Then we also have something called as a renal collar. The renal collar is basically when the left renal vein, as we've seen out here, the left renal vein is passing behind the aorta, but sometimes it encompasses the aorta, and this is called as the renal collar. Okay, because it forms just a collar around the aorta. These are just some important things that can be asked as a form of anatomy question and to test your anatomical understanding. The second disease that we need to talk about is something called as renal agenesis, and renal agenesis is quite rare. It's in 1 to 500 patients, and it's usually unilateral. It is also associated with the loss of the ureter and the hemitrigone. Hemitrigone is a part of the bladder of so it definitely is something to do with the trigone. So the bladder has a part called trigone, and its adjacent part would be something close to a hemitrigone. Definitely the better understanding would be there in an anatomical diagram, but hemitrigone in simplicity sake, if I had to just draw a diagram of an hemitrigone, so this would be the bladder, okay, and this would be where the ureters would enter, all right, and it would be surrounded by a detrusor muscle around the entire bladder, and your urethra, okay. So the point where the ureters open intramurally, that is inside the bladder, is the point where there is the urethral opening, and a little inferior to that we have this part called trigone. Okay, so this is the trigone, and from the opening till the entire urethral till the entire urethra, so let me just highlight it in white. This is the entire trigone. So sometimes there might just be atresia of hemitrigone. That means one side of the trigone is lost. So if I would think of it, this much would be lost in renal agenesis as well. So that is renal agenesis. Males can have undescended testes, and obviously females would have loss of fallopian tube. Also, in some patients, a ipsilateral adrenal is also absent. So then, if we are speaking about renal agenesis, we should also talk about duplication of the system. What actually occurs in the duplication of the system is because there is only one kidney, functional kidney. There could be two ureters, and there are two entire systems that are present. So the ureter that is more superior and more medial, all right, it opens up more distally. So as you can see, this is at its normal anatomical location, but the one that is more medial is the one that is more distal. And sometimes in female, as I've drawn in the red, it can go and it opens posteriorly into the vagina. So there would be a completely drooling or a drooping or a dribbling, continuously dribbling, or a wet vagina. So that's what the female actually comes to you with a complaint of. And because there can be opening into the vagina, there can also be an obvious UTI because of the fact that we have a lot of bacteria in the vagina. And very important to understand is that there are so many bacteria that are present in the vagina, like lactobacillus and all, but sometimes when they actually go for a toss and they are not present because of obvious reasons, like when the acidity actually decreases and the alkaline nature increases, like a perimenopausal or a pregnancy state. Sometimes what occurs is that you could have Gardnerella that is actually coming in, and the Gardnerella could be seen on a pap smear. They would be seen as an intracellular rods that you should keep in mind, and that is quite important when you're talking about UTIs. The way you could diagnose this particular condition is by you could do something called as a ureterogram or a cystogram or a urogram. A urogram would be something better, a urogram or a cystogram. So what you would do is you would do an intravenous urogram. You would administer dye intravenously, and from the dye it would get cleared into the kidney. The kidney would clear the dye, and you could see that there could be two outlets for the dye to escape. And sometimes because of malrotation you get something called as a water lily sign, and this water lily sign is quite interesting, drooping water lily sign. Then we have something called as a horseshoe kidney. Horseshoe kidney is something that you should associate with Turner, which is XO. Now, very important to understand is that horseshoe kidney is a kidney that has fused in the inferior aspect. When two kidneys are fused in the inferior aspect, they actually lead to an horseshoe kidney. What actually occurs is that kidney is somewhere higher up in the abdomen, and when it actually goes and it descends downwards, it reaches the L4 L5 area, and that is where the kidneys are usually present. But now what actually occurs is that because of the entire fusion, the superior mesenteric artery that usually lies above and the inferior mesenteric artery that lies below the horseshoe kidney is not allowing it to move. What is important to note is that the adrenals are in its normal place, so you would not have an issue with the adrenals are normal. So they would be seen as a fat, as a pad of fat in the L4 region, but obviously you would not see the associated kidney. Yes, usually these horseshoe kidney patients are asymptomatic. They do not have any kidney failure or any abnormalities on the renal functional testing, but they can obviously have certain amount of dull pain. They could have also a history of stones and hydronephros. Why would they have stones and hydronephrosis? Simply because of the kinking of the ureter that is actually being formed. So have a look at this diagram, and the ureters of for your in terms of your obvious anatomy would be slightly kinked, and because of that the stones would definitely be lodged around in the ureter. And second, there would be also a great deal of hydronephros that would be seen. So mostly whenever you see a patient in an accidental finding on an CT, you see that there is a horseshoe kidney. Mostly you do an asymptomatic. If the patient is asymptomatic, you do not really intervene. If the patient is symptomatic and if the pelvis is malrotated, as we've seen as the drooping lily sign would definitely be seen if the pelvis is malrotated. So if the pelvis is malrotated, what you need to do is that you need to do a pyeloplasty. A pyeloplasty is simply removing obstruction at a pelvo-ureteric junction, that is at the pelvis and the ureter. That would be somewhere around here, as in the white out here. So you do a pyeloplasty. You remove the obstruction at the pelvic and the ureteric junction. You anastomose the ureter with part of the kidney, the pelvis, and that's how you would treat a horseshoe kidney. Obviously, there is going to be an increased risk of horseshoe kidney associated UTIs. Next syndrome that we actually need to take into account is something called as polycystic kidney disease. Now, polycystic kidney disease can be of two types. It could be infantile and adult, but infantile is usually associated with death because of hepatic fibrosis, so we do not really discuss about the infantile type of polycystic kidney disease. It's usually incompatible with life and it's autosomal recessive. However, polycystic kidney disease adult variant is the one that is autosomal dominant. So adult is equal to autosomal dominant. And they are of two variants. Obviously, one is the PKD1 and a PKD2. Also, we could talk about infantile PKD, PCKD, or polycystic kidney disease. But the infantile, you should remember that infantile is autosomal recessive, shows hepatic fibrosis, and is usually incompatible with life. What is important about each of these PKDs, especially of the adult type, is that the chromosomes that they are present on. If it is PKD1, it's on chromosome number 16, and PKD2 is going to be the square root of 16, which is 4. That's how I quite remember the chromosomes that are usually asked in the exams. PKD1 is usually associated with a lot of cyst, as the name goes, polycystic kidney disease. Because of the cyst, what actually occurs is that the cyst is going to press on the normal renal parenchyma, and the normal renal parenchyma will have decreased perfusion, and because of decreased perfusion and decreased excretion of waste, there is going to be the RAAS, the RAS angiotensin system, that is going to be activated. And as the RAS system gets activated, there is going to be a lot of hypertension. And as you have said, that the hypertension is the first symptom that could be, or the most common symptom that we actually see. After hypertension, another very important symptom is mass, and you can feel as if there is a large cyst in the mass. And in females, they might just feel that this is the polycystic ovary disease, PCOD, polycystic ovary syndrome, simply because of the fact that in PCOS, a lot of females have heard more about it, and if someone says that on a CD you see more of cyst, they would usually think that it is a PCOS unless counseled appropriately. Also, you could see a lot of hematuria simply because of the renal parenchymal damage. This hypertension, the mass, and the entire pain could eventually progress to CKD, as chronic kidney disease. The extrarenal manifestations of a PKD is going to be most commonly hepatic cysts. Cysts can be in spleen, pancreas, lungs, and colonic diverticuli. Very important, and something that is very high yield to know is actually something called as a perianeurysm. And perianeurysm is something that is associated in the circle of Willis. Secondly, something very important to associate with PKD is mitral valve prolapse. Mitral valve prolapse is also seen in Marfan syndrome, as we know of, and it does come as a systolic ejection click. Also important to note is that there could be a lot of cysts in the spleen, pancreas, and lungs, especially in the liver, causing hepatic fibrosis as well. Very important to note is how we diagnose PKD is we do a USG prenatal, and prenatal USG can actually show you prenatal, that means inside the womb. If there are more than 3 cysts, could be unilateral or bilateral, or more than 2 cysts in each kidney, you can diagnose as polycystic kidney disease. Usually the pain is due to hemorrhage inside cysts or renal stone. The only management of polycystic kidney disease is to actually go for a long-term dialysis. The other terms of management could be transplant. However, getting a good transplant with a good graft is usually quite cumbersome for a matter of fact. And we could also do vasopressin antagonists like tolvaptan and vaptans, simply because of the fact is that because these cysts are actually causing an increase in ADH, which is also causing an increase in retention of urea and creatinine, which is causing a dysfunction in the renal kidney tests. So you could give tolvaptan and other vaptans, to make sure that you do not have any of these rise of creatinine. Second disease that we should talk about is the MDK, which is multicystic dysplastic kidney. And multicystic dysplastic kidney is again not compatible with life. It shows atresia of one side ureter, and it's also its presence as an abdominal lump at birth. Quite recently, I had seen a case in the pediatric department where for the first time I could feel, or I could palpate a kidney without any deep palpations that are indicated, the 2-hand palpations. Just simply by my fingers, I rested my fingers around the lumbar region in the iliac in the iliac fossa and went upwards towards the lumbar region, and you could definitely feel the entire kidney. On history and further evaluation, we found out that this patient was diagnosed with cystic kidney disease. However, it was at that point of time unclear of what kind of a cystic kidney disease was the child actually suffering from. Very important to note was that in spite of cystic kidney being diagnosed, there were months and almost months of neglect in terms of treatment that could have been initiated with the child, and the parents did not really understand the severity of this particular disease. It's sad that I haven't been able to follow up with the child. However, it was, for a matter of fact, a very severe case of kidney disease. What is important to know is that multicystic kidney disease, and if it's especially dysplastic, is usually going to have an abdominal lump at birth, but also there's going to be atresia, and the USG is going to show a smaller kidney with multiple cysts. Coming next is a very interesting condition called hydronephros. A hydronephros could also be palpable as a large enlarged kidney or an abdominal lump. But what you need to understand is that an hydronephros is not certainly associated with cysts, but it's the aseptic dilation of the pelvic calyceal system, that is the calyx, because of the obstruction of flow. So whenever we speak of hydronephros, it is wise not to think of any infections initially, because you're speaking of aseptic conditions. However, it is important to note that an hydronephros is equally troublesome as a pyelonephros. So there are two causes of hydronephros. The first is the unilateral cause, and then we have the bilateral cause. So first, looking into the unilateral cause, first is the luminal causes of hydronephros. Inside the lumen, there could be only 3 to 4 things that you should keep in mind. One is stones, and the other is your papillae. Now, your stones could be your calcium oxalate stones or calcium phosphate stones or ammonium stones, or your struvite, which is your ammonium stones, or even your citric acid stones or citrate stones. Many stones, and we will get into the stones as we speak forward, but let's talk about papillae as well. Now, papillae would be actually the renal papilla that could actually undergo necrosis and seen as sloughed papilla, and they are seen in analgesic abuse of NSAIDs, analgesic abuse. So sometimes they have actually been implicated with NSAIDs and acetaminophen, so that there is a history of increased intake of aspirin and acetaminophen, and you can see a lot of renal papillae necrosis causing hydronephrosis. Then you have mural causes, and mural causes are the ones that are muscular causes, intramural. And very important to understand is your PUJ and transitional cell carcinoma of the pelvis, and last but not the least, uretrocele. PUJ, transitional cell carcinoma, and uretrocele. Now, PUGA is your pelvic ureteric junction, and usually the PUJ is the most common cause of hydronephros when it comes to congenital causes, congenital. And what actually occurs in this PUJ is that there is no physical contraction at the pelvic ureteric junction. So indirectly, there is a certain amount of obstruction that you could say at the level of the PUJ. And usually the most common site of a constriction in a ureter is also at the PUJ. There are 3 sites of constrictions, as we know, of the ureter, at the PUJ, at the inlet, and also at the pelvis. At the pelvis, that is at the pelvic brim. The most common site of a constriction of the ureter is obviously going to be the PUJ. Investigation of choice is your MAC3 scan. Your MAC3 scan is very important, and the management again is your something called as your pyeloplasty. As I told you, that the pelvis is cut and then it's reanastomosed. It's called Anderson-Heinz pyeloplasty. Transitional cell carcinoma of the pelvis is done by your intravenous urogram, and what you could see is that you could see a goblet or a champagne glass appearance on your pyelogram, because there is a TCCU, a transitional cell carcinoma, and that would appear more of a champagne glass on your urogram. And then we have ureterocele. These are just normal dilations of the ureter, and they actually cause ineffective drainage of the urine, and they are usually 10% bilateral. And when you do a pyelogram, or when you do a urogram or intravenous urogram, what you could see is that there is something called as a cobra head, because of the fact is that this actually opens up into the bladder like a cobra. Pardon my drawing. Then we have the extraluminal causes of hydronephros, and the first one that we need to keep in mind is your aberrant renal vessel. Now the idea is that it's usually unilateral, and it actually compresses the pelvis from outside. You never cut the vessel because it devascularizes the parenchyma of the kidney. The only thing is management of pyeloplasty. What you could do is you could again cut at the pelvis, and then you could reanastomose in a way so that it bypasses the aberrant renal vessel that actually contracts the ureter from the pelvis. So that's very important. When I say aberrant renal vessel, you want to think of pelvic constriction. Then a very important fact is the different cancers that we have, advanced cancer stages, and you should know of 3-4 cancers that are very close to the ureter. Obviously is your sigmoid cancer, you have your rectal cancer, you have a cervical cancer, and the retroperitoneal sarcomas, and cancer of the prostate. Usually cancer of the prostate is going to cause a bilateral hydronephros, simply because of the fact that they will cause constriction of the urethra instead of the ureter, and there would be urine built up in both of these sites, so eventually they would cause a bilateral hydronephros. Cancers that are associated with unilateral hydronephros are your rectal cancer, are the cervical cancer, obviously of one side, and retroperitoneal sarcomas that can be seen. Also, sometimes we've got something called as a retrocaval ureter, and a retrocaval ureter is a ureter that goes behind the inferior vena cava, and because it goes behind the inferior vena cava, it usually disappears. It comes as a reverse J. So, for instance, let's say if this is the kidney, and the ureter would usually go in front of the IVC, right? It would go in front of the IVC. What happens now is very specifically it goes behind the IVC, and when it goes behind the IVC, it makes an inverted J. So it's called the fish hook or the reverse J ureter. You could lateralize the ureter, cut the segment behind IVC. You cut the segment behind IVC, and you do a ureterostomy, and that is as simple as it gets. Retroperitoneal fibrosis is something very similar to retroperitoneal sarcomas in the kind of mechanism of obstruction, but the entire disease itself is quite different. It's called your Ormond's disease, and the Ormond's disease is very interesting because it causes fibrosis, which is usually idiopathic, or it's IgG4 mediated, and IgG4 mediated I have seen a lot of, which is especially your Peyronie's disease. It is also something like Dupuytren's contracture, which is of the palm, the entire fascia of the palm, and it's also seen post radiotherapy if there is a sarcoma, and it would cause a Maiden-based deformity. A Maiden-based deformity is basically the ureter would go something like this, and if you would understand, this would be the quite desirable waist for any woman, so it's a maiden waist deformity. Bilateral hydronephrosis are usually caused because of the fact of any unilateral obstruction on both sides for obvious reasons. Bladder outlet obstruction, any bladder outlet obstruction, BPH, as I already told you, a cancer of the prostate. A posterior urethral valves, which is type 1 most common. Actually, there are 3 types of posterior urethral valve. Phimosis is something that is very interesting because of inability to retract the foreskin. And then the meatal stenosis. The meatal stenosis is very important, not to be mistaken with mitral stenosis. Let me just write it meatal. All right. So then, whenever you look at this case of a hydronephros, you would definitely think of increased serum creatinine, increased blood urea nitrogen, severely increased. And then when you do a diagnosis, you would definitely see that there are calyxes. This is how the normal calyx would. Then there would be blunting, and then there would be complete clubbing. All right, so there would be clubbing. Now, clubbing is bad out here as well as in the respiratory system, and that's how I remember it. The only way you could do you do your diagnosis for your PUG or for any of these obstruction is that you do a renal isotope scan, and then you do a MAC3 scan, so that you would know the total GFR and your differential GFR. So your MAC scan is going to tell you which kidney is affected. Obviously, if it's bilateral, you would know directly by the GFR. But sometimes when it's unilateral, you need to know which kidney is affected and which is undergoing hydronephros for your increased creatinine levels. So you should do a MAC scan for your PUG obstruction. And also you could do a DMSA scan, which is S is standing for scarring. You could think of it in that terms. So the kidney that is scarred is definitely something that is associated with hydronephrosis, and you would know via intravenous urethrogram and your urogram that you would see that the calyxes are undergoing clubbing or blunting, and that would definitely point you towards hydronephros. And in a hydronephrotic kidney, if it contributes to greater than 20% of the entire GFR, you can say that you are safe. You do not need an entire nephrectomy as such. But sometimes when they do not improve, you definitely need a nephrectomy. And you could do that, okay? And if the kidney contributes to greater than 20% of the GFR, of the total GFR, you could also do something called as a nephrostomy to make sure that the kidney gets rest. And that's how. So what you would do is that you would make sure that the urine is now coming out from the ureteric pelvis and going into a bag that is placed outwardly. That's causing a stomy, obviously, as we've seen as ileostomy and stuff like that, a gastrostomy procedure. And on similar accounts, you could do a nephrostomy. Coming to vesicoureteral reflux is a simple idea where it's seen in 3 to 5% of girls, and it's more common in girls, obviously VUR, and it's way more common in girls. It's actually one of the causes for UTI as well in women. And there are gradings where you see normal reflex into the non-dilated ureter. So as you go from grade 1 to or grade 0 to 5, you will see that grade 0 is normal. 1 would be in a non-dilated ureter that you would see, definitely you see ureteric reflux. And then as you go into the 5th one, there is severe distension of the ureter, severe distension plus your papillary impressions are lost. That means you would no longer have your calyxes, but they would be rather clubbed. And blunting of calyces would be definitely be seen. So that is really interesting when you come to the stagings of VUR. So the way you could treat a VUR is that you do antibiotic because of the increased risk of a UTI, and most of them usually resolve. But if it goes into grade 4 to 5, we need to do antibiotic prophylaxis, and then we need to do interventions like the STING and HIT. STING is your sub-ureteric Teflon injection, and when you do an ureteric Teflon injection, basically you're making sure that there is only forward flow in the bladder and not the reverse flow. Also, you could do a laparoscopic reimplant ureter, a Leadbetter Poliado technique. Quite interesting, and for a matter of fact, is that you do just a complete reimplant of ureter. However, it is more long and it's more difficult compared to the STING and the HIT endoscopic procedures. Very important to understand is that VUR could eventually lead to pyelonephritis, and if pyelonephritis goes to chronic pyelonephritis, it could lead to renal parenchymal scarring and obviously necrosis as well. Then you need to make sure that you get a VUR, and after you do a IVU, you make sure you have VUR. If there's a pyelonephritis, you need to go for a renal transplant. Then talking of renal stones, and in renal stones, it's one of my most interesting topics because of the fact that it's quite interesting simply because of the different types of stones that we have. And it's important to understand is that when there is more of the saturation product and the solvent is less, the solute is more, the stones are formed. So first stone that you should talk about is your calcium oxalate stone. It is most common renal stone. It is radio opaque. It is found in the acidic urine. So I'm not going to write much about renal stones because you just need to listen to me for this. We have calcium oxalate as the first stone. Then we have your ammonium phosphate or a triple phosphate stone or a struvite stone or a staghorn stone. All right. Then we have another stone which is your dihydrate stone. All right. And then we have very important is your cysteine stone, and then your uric acid stone and ammonium urate stone. Ammonium urate stone is less common. So for now we have 4 important stones: calcium oxalate stone, ammonium struvite or your ammonium triple phosphate stone. You have the uric acid stone and the cysteine stone. Now calcium typically being an alkali, obviously you need acidic urine, and when there is acidic urine you will have ionization, and when there is ionization, calcium binds with oxalate and it forms a calcium oxalate stone. When there is ethylene glycol or when there is certain amount of Crohn's disease, there is increased calcium and oxalate absorption, especially oxalate. So the way you want to treat this is that you want to make sure that you give increased calcium in Crohn's disease so that it could bind to oxalate and you would definitely leave. Vitamin C overuse can also cause certain amount of calcium oxalate zone. It's very important. And the other way you want to treat this is by giving citric acid. Citric acid is going to bind to oxalate and it's going to leave from the entire intestine and it's going to be excreted out. But what is important to note is that you should make large doses of pyridoxine being one of the vitamins, and cholestyramine. And cholestyramine is another very important bile acid that actually binds to oxalate in the gut and reduces the incidence of your calcium oxalate stone. Very important to note is that calcium oxalate is radio opaque, so you would actually see it in an X-ray, and it's one of the most common stones that we have. Calcium phosphate stone would, on the other hand, would be with the increased excretion of phosphate in the urine. However, the excretion of phosphate does not actually occur. It would occur in the cases of hyperparathyroidism, where there is increased PTH, primary hyperparathyroidism because of a PTH tumor. Very important to note again is that you would have dihydrate envelope stones, or you could have a dumbbell shaped stones. When it comes to calcium oxalate, very rarely that the stones, the shape of the stone is asked. Very important to note is that a triphosphate stone is a stone that is actually a coffin lid crystal type stone. And triphosphate stone is actually formed due to infective organisms like Proteus klebsiella and other urease positive organisms. What they do is that they convert urea from urea to ammonia, and this ammonia is actually going to bind with phosphate in an alkaline nature of alkaline urine. As I said, because ammonia and ammonia has to be formed, and ammonia to be formed you need urea. So with urea and in an alkaline environment, you would see these coffin lid crystal, and they would be struvite stones. All right. The only medical management for your struvite stone is that you make sure you give acid or hydroxyaminic acid or acetic acid. That is going to cause acidification of the urine. And with acidification of the urine, there would be decreased amount of crystals. Then we have cysteine stones. Cysteine stones is associated with a very classic case of cystinuria, where there's loss of this CoLA receptors that actually causes absorption of cysteine, ornithine, leucine, and arginine. Lysine and arginine, not leucine. My bad. Again, cysteine has to be acidic to form stones, so the urine has to be acidic, and you would see very interesting hard crystals which are very difficult to break. Then we have the uric acid crystal, and again, as uric acid is acidic, you should have acidic urine. Very important to note is when it's your acidic urine, that it could form crystals that are like glass shards, and it's seen in gout and tumor syndrome. You want to treat it by allopurinol, febuxostat, and drugs like these. Allopurinol being a combinative allosteric inhibitor, but febuxostat not being such. Other rare stone that you need to keep in mind is your xanthine stone, xanthine and tramtrine stone. Tramtrine is a potassium-sparing diuretic. Indinavir is another very important substance. Indinavir, lopinavir. Indinavir being an antiretroviral drug, specifically to be specific, it is of the class of lopinavir, that is your neuro RTI inhibitors. All right. And it is going to have flank plane, colicky pain, renal angle, and loin to groin pattern. Investigation for your stones is doing an X-ray, because most of them are radio opaque. The only one that is radiolucent is the uric acid stones, and obviously uric acid would be definitely brought upon by clinical diagnosis as well. Management, if it's 5 to 6 mm, so you just do observation with recurrent observation, because it would just pass. If it's greater than 5 to 6 mm, you want to do an extra corpuscular shock wave therapy, but you would not do this in cases of pregnancy, uncontrolled bleeding, or a cardiac pacemaker. Especially if the stone is very hard, it could cause actually an obstruction and even bleeding. So you don't want to do your extra corporeal shockwave lithoscopy. But what you want to do in such cases would definitely be you do a percutaneous nephrolithotomy. If you directly puncture the parenchyma, and you make sure that you remove the stone if it's in the lower calyx, and your retrograde intrarenal surgery, aka renoscopy, lithotripsy. So very important to understand is that we cannot give shockwave therapy, and we want to use YAG lasers. Lasers can be used, but if there is an obstructive system, you definitely want to go for a percutaneous nephrolithotomy. So to summarize, if ESWL is contraindicated for XYZ reason, you want to go for a PCN or RIRS. And if they fail, you want to do a pylolithotomy or nephrolithotomy, which basically means, again, going up and incising and then eventually retracting the stone. So you could do a ureteroscopic removal, that is RIRS, as I told you. And now let me explain what a urethral lithotomy means. Urethral lithotomy means incision lithotomy. And as you make an incision, you remove the stone, and then you use Vicryl sutures to actually cause the entire stitching. And then you do a double J stent, DJ stent. Most common type of bladder stones, when you talk about bladder stones, there could be primary or secondary. Primary is when they are non-infected, and it's more common in children, and they are usually the urate stones, phosphate stones, and jack stones, and they resemble the calcium oxalate stones, but they usually present with pain and hematuria, and investigation of choice is your non-contrast CD. First thing you do is you do a perurethral removal or a cystolithotomy. And the contraindication for perurethral cystolithotomy is that there is a urethral stricture, or it's a very large stone or stone in the bladder diverticulae, and that's when you have to do your cystolithotomy. That means that you go from the suprapubic side and you make sure that you make a line, you make an incision, you do a cystolithotomy, you make an incision in the bladder, and then you get the entire stone out. You make sure the bladder is full, you incise the bladder, and you may get the stone out when you do a suprapubic lithotomy. Such methods of aggressive lithotomy have to be used for renal stones. There's something called as an anatrophic nephrolithotomy, incision along the broader line, that is the avascular plane in the kidney. Broader lines are the avascular plane in the kidney. You do an anatrophic nephrolithotomy. You open and go from the posterior aspect of the L4 and L5, and then you open and you make an incision and you make sure that you get the stones out. And that is about it for kidney stones and the first part of kidney. The second part of kidney will be speaking about the different types of renal infections that we have, especially the papillary ulcers and the renal TB that we have. And then we'll be jumping on to pyelonephritis. And pyelonephritis is two forms: hematogenous ascending infection, about UDI, pain, fever, nausea, vomiting, burning, micturition, obviously seeing cast along with hematuria. And to rule out pyelonephritis, you would definitely have to do a CECD, and you could see opacification of the affected parenchyma, the most common organism being E. coli. Then we would look at emphysema, that's pyelonephritis, again seen in E. coli, fever, pain, and gas around the kidney. And you would have to do antibiotic and drainage. And if it fails, you need to do a nephrectomy, as we've seen in hydronephros as well. And then there's something called as xanthogranulomatous pyelonephritis, which is again in Proteus more than E. coli, and that's again very interesting to note. Also, we have to look at retroperitoneal and renal trauma, and then grades of renal trauma. And after that, finally, we will be getting into entire the various cancers that are associated with the kidney. And I think that we will obviously talk about in the next video that we have about renal tumors. And renal tumors are quite interesting because of the fact that they could be associated with certain amount of conditions like Wilms. They could be associated with Vago. They could be associated with Beckman-Wiedemann, and they could also be associated with certain interesting conditions like Denish-Drash. So for now, I think we would definitely end this lecture. And if we want to talk about, we could talk about a little bit of renal infections and renal TB, but that will go in the next lecture. Thank you.